Hi, Tiffany. All right, so we'll go ahead and get started with cardiopulmonary diagnostics. So it's a real fancy name for learning EKGs. After we finish EKGs, we spend a lecture going through hemodynamics, which is a repeat of what you've had already. So I kind of make it a review to go through hemodynamics. And then at the end, we talk about balloon pumps and A-lines. And that pretty much is the course. When we meet from 10 a.m. till 3 p.m., why so many hours? Well, it's a 2-credit college credits, 16 hours of credit, so 32 hours is how many hours we meet for 2 college credits. But it's broken up. So the morning is either all lecture, and then the afternoon is hands-on activities, or it's exam, lecture, lunch activities. There's a break for 30 minutes for you guys to have lunch, or if you need 45 minutes, that's okay too. If you want to bring lunch, eat here in the lab, that's fine. Whatever works for you guys is good. And for the hands-on activities, I'll go through the course syllabus to show you the activities. Think of something to say, my brain's got to slow down a little bit. All right, so in content, when you click on course syllabus, here's the course syllabus for all the assignments are going to the 3rd edition of the textbook. But then if you have an older edition, I have the textbook pages from the older editions. So that's why there's 3 different course syllabi showing up. Okay.
The textbook crucial to success in the class? I have other like ACLS books that cover this stuff.
Then you're fine. Then you're fine. So let me get down to that part. So for the textbook, Fast and Easy ECGs by Bruce Shade, and it says any edition. And I adopted the book several years ago. This is the 2nd edition, and it's even thicker than the 1st edition. And what I liked about the 1st edition is it was really simple to understand. And when you're learning something new, you want something simple first to understand it, and then you can build on that once you have that simple understanding. Pictures, phenomenal. Practice EKG strips, phenomenal. So then it comes out with 2. It's like, okay, it's a little bit thicker. That's okay. I want to show you the 3rd edition. Can you believe this? So for faculty, they don't give you the hardbound or the paperback bound. We put it in a binder for you. But it's huge. Look at this. So it might be intimidating. That's why I liked the previous editions. So there's a lot more information in that book than what you need. And I heard that it's $91, and I don't want you to spend $91 on it. So if you could,
It's already in the group chat.
okay.
For anyone to download.
So which one did you download? The 3rd edition?
No, the 2nd.
The 2nd edition?
That's it.
Okay. So Rachel's helping us out. She's giving you the digital copy of the book. So that'll go according to
I'll bring in, I have
the
a
2nd edition.
I have a book that I got when I was a paramedic, ACLS and also ACS. Coronary certified. They're not that big. We covered ACLS in one day and then took a test on it. It's crazy.
That is crazy. So this whole course prepares you for ACLS. You need to be ACLS certified before you graduate from the program. ACLS, you know what that stands for? Yes, Advanced Cardiac Life Support. So you already have your BLS for healthcare providers, and that's doing your compressions, some airway is taught in BLS. Advanced Cardiac Life Support incorporates intubation, EKGs, and then going through the different algorithms, meaning it's like a menu of what to do. So if the patient's rhythm changes to something lethal and they become unresponsive and all you see is it looks like artifact going across the screen and they're in ventricular fibrillation, you check a pulse and there's no pulse, what do you do? So the algorithm will say, start compressions, intubation, you want to defibrillate the patient. All right, you defibrillated, what happens? And then the algorithm will take you to the steps where, okay, the defibrillation worked. So it's like a branching logic, I guess, is an algorithm. So there's several, and we go through them, and that prepares you for ACLS. So we cover everything related to the ACLS course in this class. So when the class finishes June 24th, I recommend that's a good time for you guys to get the certification. You can shop around for a good price. I think Broward College is probably the most expensive. I think they charge $250 or $300 for the course. Yes, they do a really good job, but you can, as a group, if you say, there's 13 of us, can you give us a course? Then the provider knows that if they're getting $50 from 13 of you, they're going to make a nice profit. And they usually get through it in one day instead of the 2 days that you do at Broward College. So it helps to shop around and find an instructor that gives you a good price. But you will be ready for the course by the time you finish this 6 weeks.
If I already have ACLS, I just need to show you my credential.
Yes. Yeah, and it needs to be current when you're graduating next May.
Okay. Does it have to be specific? Like I know the standard when we did had to be like American Heart Association.
It has to be American Heart Association. Yes. All right, and then did you save your Beachy's Respiratory Care Anatomy and Physiology book?
Somewhere. Yes.
It's somewhere in your room. So when we're reviewing hemodynamics, that's what I recommend to use as your resource. And then everything else is in D2L. So there's 300 points for the class. You have 3 exams. And the first exam is on week 3. So no exam today, no exam next week. So on week 3, you have an exam. So week 3, week 5, and then the final is on week 6. Everything is cumulative because it builds on itself. We first go through PQRST, and then some abnormalities, and then arrhythmias and hemodynamics. So everything builds on itself. There's 3 online self-tests worth 10 points. And then the in-class demonstrations are each worth 10 points. So today it'll be placement of chest leads. Next week, you'll go through BLS skills. I need to observe how you bag valve mask the mannequin, and I need to observe your compressions. We have a Ambu Smart Man, I think it's called. It's a mannequin that can tell if you're depressing 2 inches into the chest. And then we count your rate and figure out if you're doing compressions fast enough.
You just got all these old backpacks at Broward Health, and they have a thing that goes where they put the pads on. It has a compression analyzer. That,
Oh, really?
will let you know if you're, speed up your compressions or.
Wow.
When I got to do CPR, it was the same thing. They had that on the person that I did CPR on.
Yeah.
So it was letting me know if my compressions were good enough.
Was it hooked up to a life pack monitor or Zoll monitor? Or?
I think so. I really wasn't looking at that part of the time. I
Ah,
was terrified, but I think so.
Yeah, the only problem with the Zolls and with pad placement is if the patient comes in on a Lucas, which is the automatic compression machine, it's hard to get those pads on when the Lucas is applied.
oh, I see. They have to be put on before Lucas is put on.
They still have the old life packs, and we used to just like connect right to their pads. Their pads are put right into the old life packs, but the Zolls are different connection altogether. So we have to put our pads on, and the pads placement on the front or the back. So you actually have to do a barrel roll the patient to get the back pad on, and then the front would have to go right where the Zoll does the compression. So it's a little more difficult in that respect. And usually if they're on the Lucas, we go to the bottom of the compression analyzer. Just
Oh, okay.
You can throw that to the side and just put the pads on. It's still covered.
And then beginning with week 3, we go through the VFib VTAC algorithm on Megacode Kelly. So I'll set you guys up in teams, and there's like 4 different positions on a team. So your team has to go through the Megacode 4 times. So everybody is doing every position. And then you're checked off on that. And so the way that I have the course schedule set up is what we're going to be doing for the day, the reading assignment in the textbook, and then assigning, they have strips where you can look at the strip and practice what it is. And then they also have questions that review what you learned in the chapter. And so that was it. First exam is on the 31st, so don't party too much over Memorial Weekend. When your online self-tests are due, and then that's it. So we finish on the 21st is when you have your final. And then the rest of it is just the course objectives.
Remember when the Super Bowl, we had a test the next day, guys?
That was a kid.
All right, so we'll get started on lecture. 10:20, I'll lecture until 11, give you like a 10-minute break. And then I'll lecture until noon, and then you guys can have lunch. So learning EKGs, as far as a respiratory therapist is concerned. When you take your national exams, you are tested on two arrhythmias. Ventricular fibrillation, that's when the heart's quivering and is no longer pumping. Or ventricular tachycardia, which is a really fast heart rate, and the ventricles are just going like crazy. That's ventricular tachycardia. So those are the 2 rhythms that show up on your national exams. So why are we giving you a 6-week course in EKGs? Well, I'm practicing as a respiratory therapist. You are part of the code team at the hospital. So if you're part of the code team, you need to know what's going on during the code. You need to be able to recognize the different arrhythmias that the patient is going through. Or if it's like a normal rhythm, you have to say, no, wait, that's normal. Let's check a pulse. So you have to know that in order to be part of the code team. The other thing is with cardioversion. Sometimes patients will have an arrhythmia and medications are not changing the arrhythmia back to normal. And so they need to be cardioverted. And cardioversion is using paddles on the chest, but a lower voltage than what you see used in these, in the code blue, and you have to defibrillate a patient. Cardioversion is using paddles. It is applying a shock to the heart, but it's low voltage. And it's meant to restart the the cardiac conduction in the heart. Well, sometimes when cardioversion is done, instead of the patient converting back to a normal rhythm, they go into a systole. So that happens, now it's a full code. So to be proactive, any cardioversions require respiratory to be standby in case. So when you're called to do a standby for cardioversion, you still need to know what's going on cardiac wise to understand everything. So that's how I'm gearing what I teach you. So what I'm teaching you is really kind of skinny down from a full-blown course because you don't need all that extra stuff. So I'm just teaching you what you need to know as a practitioner of medicine. So we're going to start with a review of cardiac anatomy and physiology. And I'll put some of the notes in the chat, and I'll also ask you to take notes. So we know that the heart is located in the mediastinum, and 2/3 of the heart is to the left of the mediastinum, or left of the sternum. So 2/3 left of the sternum. So we have the sternum in the middle of the chest, and 2/3 of the heart are over to the left of it. So when we're doing chest compressions, why is it that we compress over the sternum in the very middle of the chest? Why don't we compress over to the left?
Just because it evens it out.
Yeah, pretty much.
Pumping out the blood for them.
So when your hand goes down on the chest, you're increasing the pressure in the thorax. And it's the all-around pressure that squeezes the heart and pushes the blood out. So it's not like you're directly pushing on the cardiac muscle itself. You're pushing on the sternum, that increases the pressure and squeezes the heart, and that's what ejects the blood. So that's why you keep your hand over the sternum. Okay, and then this shows the base of the heart versus the apex. So the base, usually when we think of the base of a mountain, we think of the bottom of the mountain, and that's where most of the mountain mass is. With the heart, all the major vessels leave the heart at the top, and that's why it's called the base of the heart. So that's where you have all of your major vessels leaving the heart. And then the apex of the heart is actually a point in the ventricles that at the bottom of the heart. So the apex is actually at the bottom. Okay, so I need to write down exactly where the apex of the heart is. My notes say that it lies anteriorly at the level of the 5th intercostal space in the left midclavicular line. So let me type that in. So the apex of the heart, remember that's the bottom of the heart, it lies anteriorly at the level of the 5th intercostal space and the left midclavicular line. So middle of the clavicle, 5th rib is where the apex of the heart is. So when you're listening to heart sounds, listening at the 5th intercostal space, midclavicular line, is the best place for hearing the valves closing or hearing heart sounds. Okay, and then it talks about the pericardium. So the layers surrounding the heart are the pericardium. And there's 3 layers. No, I didn't say that right. So there's 2 layers to the pericardium. Pericardium. 2 layers to the pericardium, not 3 layers. And it's just like surrounding the lungs. We had a layer of tissue surrounding the lungs called the visceral pleura. Well, for the heart, it's the visceral pericardium. So that's like some tough tissue that surrounds the heart muscle. Then there's another layer, the parietal pericardium, which is on top of that layer. So in between the visceral pericardium and the parietal pericardium, you have the pericardial space. So in between the 2 layers is the pericardial space or the pericardial sac. It's important for us to know that this potential sac exists because sometimes, like with a stab wound to the heart, blood starts going into that pericardial sac and fills the pericardial sac with a lot of blood, and that squeezes the heart and makes it really hard for the heart to fill with blood because it's being squeezed by all that liquid or blood that filled up the pericardial sac. We talked about this during your first semester where we talked about.
Is that cardiac tamponade?
Yeah, very good. We talked about cardiac tamponade. Good job. All right, and now the next bullet is 3 layers of the heart wall. The inside layer is called the endocardium. So the endocardium is the layer of the heart that the blood is exposed to as it's going through the heart chambers. So that inside layer is called the endocardium. The next layer is the myocardium, and that's the muscle layer of the heart. And then the outside layer is called the epicardium. So that's the outside layer. So the epicardium and the visceral pericardium are one and the same. That's not a test question. That's just a little bit of trivia. I think the important part to take away from the different layers of the heart wall, to know endocardium is that inside layer, and then to understand myocardium is the muscle layer. I remember being in college, at University of Detroit, and there was a guy in biology class, and he says, "I'm not going to be in class. My father had a myocardial infarct." And I said, "Oh, okay." And I walked away like, what the heck is that? What's a myocardial infarct? So oh, okay. Death to the heart, but I didn't realize that myocardial meant the muscle tissue is dead because of lack of blood flow. So myocardial infarct, dead muscle tissue in the heart. So that's what an MI is. Here's an artist's rendition, or is this just a picture of a model maybe? It's a model. So it shows how the heart sits in the mediastinum. You see how it's surrounded by lung tissue? And then when you're looking at the heart, it sits on the diaphragm. And that becomes important because sometimes and then below the diaphragm is the stomach. Sometimes when patients are having poor perfusion to the heart and they're having chest pain, one of the presenting symptoms is they have indigestion. It's like, oh, I don't feel good. There's something going on in my stomach. And it's actually poor perfusion to the heart causing referred pain. And it's because of the way the heart sits on the diaphragm. And then right below that is the stomach. And then it says also, notice the left ventricle faces front and to the left side. So the left ventricle, a lot of it is facing anteriorly or to the front of the chest. And then to review the different chambers of the heart, when blood is being returned from the body, from the inferior vena cava, superior vena cava, it drains into the right atrium. So that's considered a collecting chamber of the heart. From there, the blood will flow down into the right ventricle. So that's the second chamber, is the right ventricle. Then the heart contracts, and when it does, it pushes the blood in the ventricle into the pulmonary artery. That pushes the blood to the lungs. And then when the blood returns from the lungs, it returns into the pulmonary veins, which is connected to the left side of the heart, the left atrium. So the left atrium collects blood flow coming from the lungs. From the right lung, the left lung, it all drains into the left atrium. And then from there, it'll flow into the left ventricle. And then when the heart contracts, the blood that's in the left ventricle will be forced into the aorta. And then of course it goes to the rest of the body. Okay, so some questions. The right atrium receives blood from where? From the inferior and superior vena cava. The right ventricle pumps blood to where? Into the pulmonary artery. Why is that called the pulmonary artery when it has deoxygenated blood? Yeah, so any vessel that takes blood away from the heart is called an artery, whether it has oxygenated or deoxygenated blood. Most of the time it is oxygenated blood in the vessels going away from the heart. The exception is the pulmonary artery. So when the blood returns from the lungs, where does it enter? Left atrium. Okay. And when the left ventricle contracts, where does it pump blood to? The aorta. Very good. And then a question, why does the left ventricle have a thicker muscle wall compared to the right ventricle? Very good. So the left ventricle is pumping against more resistance. All those blood vessels going systemically create a much larger resistance. Okay, and then for the heart valves, we have the first valve, the tricuspid valve, between the right atrium and the right ventricle. Do you have a way of remembering the name of the valves? How do you remember the tricuspid valve is between the right atrium and the right ventricle? You just do?
Yeah. Sarah wouldn't know it.
So I see RI in the word, right. So that's how I remember tricuspid is on the right because of RI for right. Pulmonic valve and pulmonic valve is how the next valve is referred to at the hospital. But when you were taking your anatomy and physiology, you learned it as what, semilunar valve? Yeah.
Is that bicuspid?
No, the bicuspid valve is the mitral valve. So the valve between the left atrium and the left ventricle is the mitral valve. That is two cusps or bicuspid. Do I have a way of remembering the name for mitral valve? No.
The L in the mitral for left.
Yeah, okay, there we go. Thank you. Mitral valve is on the left. And the aortic valve, it's called the aortic valve in your A&P class. It's called the aortic valve at the hospital. Valves that need to be replaced the most when there's damage to heart valves, it's usually the mitral valve. And I always remember why only two cusps? Maybe if they made that mitral valve, the creators of our bodies, made the mitral valve tricuspid, maybe there wouldn't be so much damage to it. So that's just me in my mind. I create stories to remember things. That's how I remember mitral valve has two cusps, is because problems usually occur because there's only two cusps, which is completely wrong. It's just a way to help me remember. So yeah, a lot of times that valve has to be replaced. So they'll put a pig valve in there or a synthetic valve. Okay, and then go away.
Vacation in the verbal,
Sorry.
including all the craziness from life. Well, maybe
I
not
should have
all.
pulled it up
Crazy
before.
feels good when it has room to-
So listening to heart sounds as a respiratory therapist, no, it's not part of our responsibility. I just wanted to point out a couple things for heart sounds. So when the heart valves close, that's what creates the sound that we hear when we're hearing with our stethoscope. First, we hear the AV valves close, the valves between the atria and the ventricles. We'll hear those close first, and then it'll follow by the pulmonic and aortic valves closing, and that forms the second sound. So the S1 sound, like, is sometimes it's referred to as the sound of lub, and then the second sound is referred to as dub, just from the using words to mimic the sound. And then it gets into a lot of details that we don't need to know as respiratory therapists. It just tells you that hearing sounds, it's loudest at the apex of the heart, which is the fifth intercostal space, mid-clavicular line. And when you're using your stethoscope to listen, do you have the stethoscope that turns between a smaller ring and a wider ring? So the smaller ring is meant for listening to heart sounds. I guess that's really low intensity sounds. And then the larger one is for listening to breath sounds because that's a little higher intensity than the valves closing. But sometimes you just press, if you just have the one diaphragm, then you press on it more firmly when you're listening to heart sounds, or no, is it the opposite? All right, I'm gonna have to look that up, unless you guys remember. When you got your stethoscope, if you got a Littman and you're not turning between the two, if it just stays on one, when you press lightly, you hear one type of sound, and if you press firmly, you hear another type of sound. You guys were not told that? All right, let me write myself a note to look that up.
When I got mine, it's in the small ones with pediatrics.
Oh, no kidding. So, and then you could do that because of the smaller size to fit on their chest. Chordae tendineae are these thick tendons that attach the valve to the heart muscle. And what's interesting is, how do you think the valves open? So I always thought that something contracted and pulled the valves open, but nothing contracts. When the heart muscle relaxes, it goes outward and that pulls the valves open. So there's no muscle contraction that opens the valves. It's just the ventricle relaxing and that pulls the valve open. So that's another piece of trivia that's not on your test. Let's see. All right, so the blood vessels that feed the heart muscle, we have to know about that, especially when we're getting report from OR that a patient had a cabbage and the LAD was occluded and had to be bypassed. It's like, what are they telling me? So let's go through some of the terminology that goes along with blood flow to the heart. For one thing is the blood, nope, I didn't say that right. The heart receives its blood flow during diastole. That's different than the rest of the body. The rest of the body receives its blood flow during systole. The heart contracts, pushes the blood to the body, and that's when the blood flow goes to all the organs of the body. Except for the heart, since the heart is contracting, it can't get its blood flow at that point in time. So it's when it's relaxed is when it actually gets blood flow. All right, and then the two main, oh, and this is important to know too. The coronary blood vessels, there's two of them. They arise from the aorta just after the aortic valve. And it took me a while to learn this because I've looked at so many pictures of hearts and they never show where the coronary vessels attach to the aorta. So I'm really excited about this picture. I know you guys think it's boring, but so right after the aortic valve is where you have the coronary arteries branching. So the left coronary artery, of course, feeds the left side of the heart. So that's a no-brainer. But there's a couple branches of the left coronary artery that become occluded. The first one is the LAD, or the left anterior descending. And of course, you only hear LAD when you're at the hospital. So anterior means it comes to the front of the ventricle, and descending all the way down the wall of the ventricle. Is there anything else I wanted to tell you about the LAD? Yes, there is. I can put it in the chat. So we said the LAD feeds the left heart, but then it breaks it down. The left atrium, the left ventricle, the lateral wall and the anterior wall. So let me write that down.
this picture, this view is kind of from the, looking at it from the right side almost. Is it? It's a little bit, because we're looking at the posterior branches as well coming out of the right. You would normally see those.
Yeah, it's supposed to be showing you what's wrapping around the back.
Isn't it for like the, isn't the right circumflex go circling around the back?
So left anterior descending. So we have, this is showing what's anterior. And then it starts wrapping around. So here it looks like this vessel is in the front, but it actually is wrapping around to the back. Maybe it's kind of hard to tell, like they make it a little more fuzzy to mimic going around to the back of the heart. Here, yeah, all the fuzzy vessels are actually on the back. All right, so. So we need to know a little bit more detail about the LAD. It does feed the anterior wall of the left ventricle and the lateral wall of the left ventricle. And of course, the left atrium. Now let's talk about the right coronary artery. Okay. And then the circumflex.
Little bit on the chat side.
Yeah. Is that good?
Yes.
Sorry. Let me just read it all and then I'll stop so you can write it. So the left anterior descending feeds blood flow to the left atrium and the left ventricle. The parts of the left ventricle fed by the LAD include the anterior and the lateral wall. The right coronary artery feeds blood flow to the right atrium, the right ventricle, also feeds blood flow to the posterior wall of the left ventricle. So the right heart doesn't have to work as hard. Maybe that's why it can share its blood flow with the left side of the heart. So the right coronary artery does wrap around and give some blood flow to the left ventricle, but it's the back wall of the left ventricle, which we say posterior wall of the left ventricle. And then as far as blood flow to the SA node, sometimes it's the right coronary artery, sometimes it's the circumflex artery that feeds blood flow to the SA node. Why do we care about this? When the patient has no impulses coming from the SA node, that's a flag. Oh, wait a minute. If the SA node is not working, that means one of the blood vessels feeding the SA node has been occluded. So it's kind of a way of finding out where the damage is occurring by what the symptoms are. All right, so that's memorization, but for the most part, isn't it easy to memorize? Left coronary feeds the left heart, right coronary feeds the right heart, and then just a few more details to throw in there. Okay. All right, now to talk about collateral circulation. I have growth of new blood vessels. If you want to write that down, growth of new blood vessels is what collateral circulation is. Growth of new blood vessels. And then write down, it's a long-term process, I guess. A long-term process that occurs when there is a slow change in perfusion. So it's long-term, which can occur with a slow change in perfusion. And then I'll put that in the chat. So I just want to explain it. All right, so when there's plaque that builds up on vessels, on blood vessels, especially the blood vessels feeding the heart, and the plaque that's building up on the vessels is occurring slowly over a period of many years, the feedback to the body is, hey, wait a minute, my muscle is not getting enough blood flow. Let me build a new blood vessel to go into this area to bring some more blood flow. So when there's plaque buildup and it happens slowly, there will be collateral circulation. So the person's body will just build new blood vessels to try to get more blood flow to the area that's not getting a good enough blood flow. And that's called collateral circulation. So if a piece of plaque breaks off, travels, and then occludes a blood vessel, collateral circulation is not going to have time to construct new blood vessels and get blood vessels passed. And that's usually when we see patients have heart attacks, is when that plaque breaks off, occludes the vessel, and now the heart muscle is not getting blood flow.
So when you have plaque that like builds up and it starts building new blood vessels, like that's also bad because is that starting to like take up more room with the ones up, and that's how like that happens because you can't get rid of the plaque.
Exactly.
So that's okay.
Yeah, the plaque stays there.
And then there's just more buildup until it like continuously keeps building, and then the plaque on the back ones is what causes heart attack. Or
Yeah. Yeah, so like chest pain can occur during exercise, and then eventually chest pain occurs at rest because there's not enough blood flow during exercise getting to the muscle. But maybe at rest, it is enough squeezing by to feed the muscle. So, all right, so let me write that in the chat, collateral circulation. Is this good? So collateral circulation occurs over a long period of time. The body builds new blood vessels if an area of the heart is not receiving enough blood flow. Good enough? You're welcome. All right, so how are blocked coronary arteries diagnosed? This is done in the cath lab in the hospital. And what they'll do is they'll thread a catheter from the femoral artery up the aorta and then into the right coronary artery and then into the left coronary artery. And once they get the catheter there, they inject a dye and then they take a picture of the dye going through the blood vessel. So that's what a cardiac catheter is. No, I sure don't.
No.
Right, so the picture, the purple arrow is showing like normal perfusion of the blood vessel. And here, the blood vessel is straight, but there's so much plaque built up that the blood can only flow through this very narrow portion. So this patient has angina, which is chest pain, and has an abnormal exercise treadmill test result. So when the patient was exercising, they were seeing changes in the EKG that showed that the heart was not receiving enough blood flow. So sometimes you're called to the cath lab at the hospital because as they're going through this procedure, sometimes putting that catheter into the coronary vessel causes the heart to start spasming and the patient will go into some cardiac arrhythmias and they'll call a code in the cath lab. Just so when you're getting oriented to whatever hospital you're working at, make sure that you know where the cath lab is. So if a code is called, you know to go in. They usually put lead aprons on you before you go into the room because they'll continue using fluoroscopy even while you're doing compressions. So something that you'd get involved in as a respiratory therapist.
Do we get exposed? Do we ever get to see that maybe in clinicals or something? We be able to visit the cath lab and actually see that when they do that?
Yes, but you're going to have to ask to see it. I don't think it's part of the competencies anymore.
I've seen it. It's just really cool.
At Broward, I don't know if they have the viewing, even the viewing room is good to go into just to watch it from the outside. I know at Memorial, there's a huge viewing room, so you can just go stand and watch the catheterization. But yeah, it is pretty cool to see. Okay, so treatment options for blocked arteries. I'll tell you this and then we'll take a break. So the first one, angioplasty, is mechanically widening a blocked artery. So angioplasty is mechanically widening a blocked artery. So during the catheterization, they'll put something in to that blocked vessel. They'll somehow get that catheter past the blockage, and then they inflate this balloon and it just pushes the plaque against the wall. Then the next step will be to put a stent. A stent it's like a wire mesh that you get from a ballpoint pen. I mean, they don't take it from a ballpoint pen. I'm just trying to give you a visual as far as what it looks like. And they put that in the vessel to keep it from occluding. So I wrote a vessel dilating spring. A stent is a vessel dilating spring. And you'll probably, maybe you've already seen this on when you're looking at patients' chest x-rays. It looks like they left a ballpoint pen in their pocket, in their left pocket, but it's not a ballpoint pen in their pocket. It's the stent showing up on x-ray.
triangles, or not a triangle, sorry. I don't know my shapes. A rectangle.
Cylinder?
Yeah, like a cylinder. Almost like a little ink cartridge.
Yeah. Yeah, so that's from a stent being placed in the vessel, and it stays there for the rest of the patient's life. All right, and then the third one is CABG, coronary artery bypass graft. And then this involves surgery, usually. Yes, it does involve surgery. I think if they're doing it robotically where they don't even have to crack the chest. So typically the sternum gets sawed in half during the surgery. And then the rib cage gets opened up. So the surgeon has direct access to the heart. Then they do it a couple ways. Most commonly, they'll take the internal mammary artery, so the blood vessel feeding the mammary glands, I guess, and they'll dissect it and redivert it and sew it into the heart muscle. And it'll start perfusing that area of the heart that wasn't getting blood flow. So they bypass that occlusion with another blood vessel to bring blood flow to that area of the heart. And that's why they call it a bypass graft. They're bypassing the occlusion with another blood vessel. So 20 years ago, and I don't know if they still do this, 20 years ago, what they would do is they would take out the veins from the legs, cut them to the right size, and then sew them from the aorta into like the LAD, past the occlusion. And you would see scars on all of your patients' legs because, they would leave a scar like from almost the ankle all the way up to the thigh. So patients would have all these scars on their legs because they took out a vein and then used that to bypass the occlusion. I don't know if that's still done. All right, so now we'll take a break, 10 minutes. I want to show you this where it says tools in D2L, and then you go to links. There's some good stuff here. For cardiac stent, there's an animation of a stent being placed in a blocked cardiac artery, coronary artery. So it's really cool for understanding how it's done. I want to keep going. Today is like the longest lecture of the 6 weeks. And I want to get through it before I lose you guys. But this is really good. So go into links and then click on it and you can watch the cardiac cath. All right, so I have on here a typical scenario of how patients present to the ER. 60-year-old woman comes to the emergency department with several hours of crushing substernal chest pain. Previously, this occurred while she was exerting herself, but it would abate with rest. Do you know what that means? Abate? Subside, go away. Yeah. So exerts, she has chest pain. She relaxes and she's okay. This time, however, it developed while standing at work. The pain is severe. It radiates down her left arm and up to her left face and is causing her to feel sweaty, nauseated, and lightheaded. So that's typically when you have poor perfusion to the heart muscle, the symptoms that are experienced when that's happening. Her medical history is notable for hypertension, high cholesterol, and a family history of heart disease. Her coworker calls for emergency help. She is given sublingual nitroglycerin. Do you know what that's for? Nitroglycerin, it dilates the blood vessels. So in this case, it'll dilate the coronary arteries, and that'll help to get blood flow past that occluded area. She is given aspirin therapy. So the benefit of aspirin is that it also causes, it's like an anti-clotting agent. It prevents blood clots from forming. So it's low dose aspirin will prevent further clots. Like she's obviously already got a clot, but to prevent it from getting bigger or to prevent further clots, they start her on aspirin therapy right away. She's transported to the local emergency department. EKG shows ST segment elevation. We get to that later on. On examination, she is diaphoretic, tachycardic, and mild respiratory distress, and obviously still in pain. A chest X-ray is clear. Her cardiac troponin assay and creatine kinase MB fraction levels are moderately elevated. So those are lab values that indicate that there's damage to heart muscle. So when they draw blood, those are the lab values that will show that heart damage has occurred. This patient has classic symptoms of angina, which is chest pain that is presumed to be due to coronary ischemia. And that means there's lack of oxygen to the heart muscle tissues that are dependent on the blood flow from the blocked vessel. This usually affects the left ventricle, but may occasionally affect the right side of the heart. Before the presentation that brought her to the emergency department, the patient's symptoms would have been classified as stable angina because her symptoms abated at rest. But now her symptoms would be considered unstable. She most likely has an occluded coronary artery that, if it persists, may result in more extensive damage. Her elevated cardiac troponin and CKMB, cardiac proteins that leak into the bloodstream when there is heart damage, such as ischemia, these levels already indicate that there has been cardiac injury. So there is little time to waste in preventing more heart damage. She therefore undergoes emergent left heart catheterization, not only because it would be diagnostic for occluded vessels, but also because there is a chance that catheterization may in fact be therapeutic. An occluded coronary blood vessel can be visualized and opened successfully by means of angioplasty and possibly placing a stent to maintain the patency of the opened artery. All right, so that's typically how the situation occurs with a patient having an MI. So for the cardiac injury markers, serum troponin. Troponin is an enzyme that gets released from damaged heart muscle. So it takes about 2 to 3 hours for this enzyme to be detected in the blood. So if the patient has chest pain, immediately goes to the emergency department, they immediately draw labs, it might show a normal troponin level because it takes like 2 to 3 hours after the ischemia before that enzyme actually is elevated enough to be detected. Peaks in 14 hours, back down in 5 to 10 days. A normal level, 0.1 nanograms up to 3.1 nanograms. So again, I use words to try to help me remember things. So I see troponin ending in NIN and nanogram is an NAN. So I say troponanogram. Troponanogram, it's measured in nanograms, nanograms per ml. Anything above 3.1 is elevated and abnormal. So above 3.1, we've got heart muscle damage. And then there's no levels that you need to know for CKMB. You'll see it on the labs, and then the lab will just indicate what the abnormal levels are. But you are asked to, is a test question on serum troponin. So you do have to know it takes 2 to 3 hours to show up, and you have to know abnormal is above 3.1 nanograms per ml.
You can remember that easily because it's 3 and 3.
Oh yeah, 3 hours, 3 nanograms. Oh, okay, very good. All right, good to go. Did I have to write anything in the chat? No. Another blood test that you have to know is BNP. BNP stands for brain natriuretic peptide. Why is it the heart muscle secreting a peptide found in the brain? So initially, or early on, I should say, this hormone was found in the brain of monkeys. I think they did it. And that's how it got its name. So they originally found it in brains. But then they realized that it's being secreted by cardiac ventricles. When the ventricles are overstretched, then it'll leak some BNP, brain natriuretic peptide. So increased levels are caused by increased ventricular blood volume or heart failure. And then for normal values, try to simplify it for memorization purposes. How about greater than 600 picograms? We'll call that as abnormal, rather than having to know what's moderate, what's severe. How about just greater than? Greater than 600 picograms per ml is heart failure. So picograms, peptide, that's how I connect the unit or the name of the lab value, picograms, peptide, BNP. Peptide picograms. So the question at the bottom, how can you distinguish between dyspnea from heart failure or dyspnea from pulmonary disease? So patient comes into the emergency room, they're feeling short of breath. How do we know what's causing that shortness of breath? Could it be that they just have asthma or COPD, or maybe they have heart failure? So how would we distinguish? Okay, so we could put a Swan-Ganz catheter in and look at our pulmonary artery pressures. And a high wedge pressure would indicate that there's left heart failure. 18, yeah. Okay. So let's say we don't have access to a Swan-Ganz catheter.
Take the EKG.
Sure.
EKG?
Yeah.
Okay. So if there's an infarct occurring, that'll show up on the EKG. All right, so that's good. Yes, so troponin, so draw some lab values. We would see an elevated troponin level, elevated BNP, and CKMB. All right. CKMB. So the cardiac cycle has diastole and systole. What do I need you to know about this? So diastole is the relaxation and the filling phase of the heart. Should I put that in the chat? Or you guys have that? During diastole, the heart fills with blood. During systole, is the heart's contracting? Okay. Which valves are open during diastole?
The bicuspid and the tricuspid.
Very good. So the AV valves are open during diastole. So the ventricles are filling during diastole. So those AV valves have to be open so the blood can go from the atria down into the ventricles. So diastole, the AV valves are open. What valves are open during systole? Yes, very good. The pulmonic valve and the aortic valve are open during systole. When does the heart receive its blood supply? During diastole. Okay, and now to review the autonomic nervous system. There's two branches of the autonomic nervous system. There's sympathetic and parasympathetic. Which branch stimulates heart rate and increases contractility? Sympathetic nerve. Yeah. Sympathetic branch of the autonomic nervous system. Which branch inhibits heart rate and decreases contractility? Parasympathetic. Good. Cardiac muscle fibers keep high concentrations of positive ions just outside their membranes and high concentrations of negative ions inside the membrane. So can you imagine in your mind a cardiac muscle cell? So you see the circle with the little nucleus, and inside the cell, imagine a bunch of negatives. So a negative charge. And then on the outside of that circle or the outside of that cell, imagine a bunch of positives. So ions that have a positive charge. So the difference between the two is called the action potential or membrane potential, because there's the potential for those charges to change. Before they change though, what you need to know is at rest, minus 90 millivolts inside the muscle cell. So a negative charge inside the muscle cell when it's resting. And I posted a link where I showed you to go for the links, and it says it's minus 70 millivolts outside the cell. I said that wrong. Minus 70 millivolts inside the cell. So you might hear a few different numbers depending on what textbook you read. So what ions maintain this action potential, keeping the inside of the cell negative, the outside of the cell positive? Okay, so the first one, sodium. How is sodium abbreviated? Okay, what was the next one? Potassium. And the third one. Yes, very good. So those are the ions that move in, inside, and out of the cell in order to change the electrical charge. The bottom, it says the concentration of potassium is much greater inside the cell. So if you burst open a bunch of cells, now you get a lot of potassium released. But for the most part, most of the potassium is inside the cell. All right, so with this electrical charge, it says when a cardiac cell receives an electrical stimulus, the inside of the cell changes in polarity from minus 90 millivolts to a plus 30 millivolts. This occurs due to the influx of sodium ions. So let me draw the cell. We have sodium. So a bunch of sodium goes into the cell. And now the inside of the cell is no longer negative, and now it's positive.
Is this essentially the sodium potassium pump?
Yes. Yeah, the sodium potassium pump is part of the action potential of the cell.
But yeah, so it goes through and comes back into the positive.
Yes, very good. When did you guys learn this?
I swear we learned it
I
with
think the
you.
first semester.
But you went over it.
Oh, okay.
Yeah.
Oh,
I
okay.
just wasn't sure if it was talking directly for the part or it was for other.
So after the cell is stimulated, then it can contract. All right, so once the cell contracts, now it's got to go back to resting again, and it returns to its negative charge. So when it returns back to its negative charge, that's called repolarization. Let me get back to so as an electrical impulse spreads to the cardiac cells, blank occurs when the minus 90 millivolt charge becomes positive. So what word do you put in there? Very good. Depolarization occurs when the minus 90 millivolt charge becomes positive. So the inside of the cell goes from being negative to being positive. We call that depolarization. And then blank occurs when the minus 90 millivolts are reestablished. Repolarization. Okay. All right, so what stimulates the muscle cells, you ask? Well, it's a special nerve tissue called cardiac conduction. Okay, so I want my mouse back. All right. So I just gave cardiac conduction a name. I said it's special nerve cells that travel through the heart and stimulate the muscle cells to contract. And then we have a slide coming up, but just while we have the picture here. So the cardiac conduction begins with the SA node. So that's a special bundle of nerves that are stimulated by different things. It could be the parasympathetic system stimulating it, sympathetic nervous system stimulating it, chemicals, like if they're circulating epinephrine, that'll stimulate it. So once the SA node receives a stimulus, the stimulus doesn't stop there. Then it's going to spread throughout the heart. And the way that it does that, the SA node will send the impulse through both of the atria. So it'll go through the left atrium, the right atrium, and it'll travel down to this other bunch of nerve cells at the bottom of the atrium called the AV node. The AV node holds the charge for a split second, and it lets the ventricles fill with blood. Then the charge continues down the bundle of His. From there, it's going to travel to the left ventricle, to the right ventricle. So going to the left ventricle is the left bundle branch. Going to the right ventricle is the right bundle branch. And then there's little fibers that go through the muscle tissue called Purkinje fibers. And now we've got the entire heart stimulated in order for those muscle cells to go from negative to positive, and now they can contract. So blank is located in the right atrium near the superior vena cava, An impulse is initiated here, and then the impulse spreads over atrial muscle to the AV node. What is the name of this area, of this SA node? Yes. So sinoatrial, but SA node is fine as far as I'm concerned. Got that? The next one, blank is located in the septal wall of the right atrium, just behind the tricuspid valve. AV node. The conduction is delayed here to give the ventricles adequate filling time. Blank penetrates the fibrous separation between the atrium and the ventricle. Yes, bundle of His. It says the nerve fibers entering this interventricular septum divide into blank. Right and left bundle branches. Smaller branches of each bundle spread throughout the ventricles. What are those called? Yes. Very good. All cardiac tissue has automaticity, and this is the ability to depolarize spontaneously. So if anything coming to the SA node was severed, so no sympathetic stimulation, no parasympathetic stimulation, no epinephrine, nothing is telling the SA node to contract. It'll do so on its own. 60 to 100 times a minute, it'll initiate an impulse. So if it's not receiving anything, it'll start its own. If the, let's say the SA node is damaged and there's no impulses that can go from the SA node down to the AV node. If the AV node isn't getting any stimulus, it'll start its own conduction. So the AV node can initiate impulses, but it's going to do that a little bit slower, 40 to 60 times per minute. So if the AV node isn't getting any impulses from the SA node, it'll do it on its own, but slow, 40 to 60.
Is that a junctional rhythm?
Yeah, very good. And then if the AV node is not sending in any impulses to the ventricles, then the ventricles will say, hey, wait a minute, I'm not getting any stimulus here. Let me do it on my own. So the ventricles can initiate impulses, but when it does it very slowly, 20 to 40 times a minute. So as we're going through the different cardiac arrhythmias, we'll refer back to this information.
Just a weird question. Is that how they measure like your heartbeat then? Like your heart rate then?
No,
Just wondering because it said 60 to 100. So
no, that's just looking at, when you're looking at a cardiac arrhythmia on the EKG, and you can understand why you're seeing a certain arrhythmia by knowing this information. All right, and now we get into measuring an EKG. More info to give you. So the EKG, on the slide, it's ECG, which is electrocardiogram. And that is a tracing, a paper tracing of the cardiac conduction system of the heart. So I'll write that down. Paper tracing, it could be digital, right? So I wrote electrocardiogram, paper or digital tracing of the heart conduction system depolarize, showing the heart depolarizing. So why am I saying EKG when it's ECG on the paper and it's spelled with a C, electrocardiogram? And do you know the answer to this? Do you know?
From another language, or it's like German or something?
Yeah, very good. So it comes from a German word, and it's spelled with a K in German. And it's pretty much sticks at the hospital. EKG is always referred to as looking at the patient, the patient's heart depolarizing. We say EKG. So ECG, EKG, same thing. It's just referred to two different ways. The action potentials conducted through myocardial fibers during depolarization produce electrical currents that eventually make their way to the body's surface. So inside your body, as your heart muscle is changing polarity, going from negative in the cell to positive in the cell, that can be picked up with electrodes. So all those cells depolarizing, it can be detected. The electrodes placed on the skin and attached to a specialized voltmeter can detect small voltage changes as the heart depolarizes and then repolarizes. This voltmeter is called an electrocardiogram. And so the machine is called electrocardiograph, and the paper or digital tracing is cardiogram. Electrocardiograph is the actual machine. That is not a test question. That's Trivial Pursuit. So an EKG or ECG is a recording of voltage against time. Leads and electrodes are used to record the ECG, and I'll tell you about the leads and electrodes when we're over there putting them on each other. So you can put the electrodes directly on the chest surface, or you can attach it to the arms and legs. If you're putting the electrodes on the chest, they're called a chest lead. On the chest, I guess thorax would be a better word. Everybody knows what I'm talking about, right? Your thorax. If you put the electrodes on your thorax, they're considered chest leads. If you put them on your arms and legs, they're considered limb leads, L-I-M-B, limb lead. And then in my notes, I have that electrodes must have good skin contact. So you may have to shave the patient's hair. Some patients have a problem with that. I'm sure at the hospital, your clinic instructors are going to tell you how to get around that. Like, what if they say, no, you cannot shave my hair? Then what? I don't know how you handle that. Also, if the skin is wet or oily, use an alcohol pad first. Make sure the skin doesn't have any oil on it, and then put the electrode on. Let's see. All right, so there's two pictures here. One is showing limb leads and the other one is showing chest leads. So RA stands for right arm. So you can guess everything else, right? So where these leads got their name is You put this on the left arm, or typically the left wrist, the right wrist, and the left leg. So when you're putting electrodes there, every time the patient moves, you get all this artifact showing up in your EKG tracing. But if you move those limbs further in and place them on the chest, now you're going to get a better tracing. It's not going to have all that artifact in it every time they move. And I'm going to have you do it both so you can see the difference in the tracing. So when you put the leads on, start off by putting them on your chest, and then do like 6 inches of the tracing, and then stop the print, move the leads to your arms and your left leg, and then hit print again and get another 6 inches of tracing and then hit stop. And then let's compare and see if there's any difference. Do they look the same? So that's what we'll do when we do that. There's 3 main electrodes needed to monitor an EKG, and they are a negative lead, you're going to put this on the right arm. You need a positive lead. And you need a ground wire. Right arm, left leg, left arm. So you have to have a negative, a positive, and a ground. All right, so instead of placing the negative lead on the right arm, you're going to move it and place it under the clavicle. So your negative lead is going to go on the right under your clavicle. Your positive lead, instead of putting it on your left leg, you're going to put it on your left rib. The ground wire, you're going to put under your left clavicle. Should I put that in the chat, or you got that?
Instead of placing on the left leg, we put it under the left rib for the positive lead.
Yes. Left rib. All right. Under right clavicle. So the electrodes are color coded, and they use the same colors. All the companies use the same colors. And the white one is always negative. So the white one is negative. The positive is red. The ground wire is black.
You said positive was red.
Negative is.
White. So as far as placing the leads on, and you do this a lot when the patient comes into the room and everything has to be hooked up. If you're at the bedside and you've already got them hooked up to the ventilator and that's done, you could hook up the leads. And I see respiratory doing that a lot. So you grab them, you've got three wires in your hand. Each one of them has a color and they're also labeled. So when you're first starting out, if you get nervous and you forget, you can memorize the mnemonic that helps you, but they're also labeled with, RA for right arm. So how I remember it is rhyming. So white on right, white on right. So right underneath the clavicle is where you're going to put the white lead, the negative lead, white on right. Red on ribs. So anteriorly on the ribs is where you're going to put your positive lead. White on right, red on ribs. And then black left over or black left shoulder is how I remember where to put the black. The black left shoulder or the black left over. It's the one that's left over. Where do you put it? Put it on the right shoulder.
This might be a stupid question. So why did we write place on left leg if we put it for the left rib? Is there like, usually you put it on the left leg, but in class we're doing it on the like left rib?
So to give you the theory first
Okay,
of how the electrodes are placed, that is how you place them when you're going to do a 12 lead. You will be putting them on the wrists and the leg, and then you'll have your V leads right on the chest. So to give you the theory first about, that's the original place, but there's too much artifact, so move it over to the chest. I could have skipped that part of the lecture and just said, here, this is where you put the leads.
No, I
But
just
when you're
wanted to
doing
know
a
why.
12 lead, you would need to know it. So.
okay.
I was gonna say, this is like they use first lead. There's different sizes of like lumps.
Different
Like,
sizes.
like a 3 lead is really small compared to like other leads are more big.
Yeah, so you just need a minimum of 3 wires or leads, they're called. And it can go up to 12 lead. I think now there's 15 and 18 lead EKGs, but we don't need to know. So you'll always start off by putting the leads exactly what we just discussed. They don't change. But then when you go over to the machine, you can change the polarity of the lead. So when you put the negative electrode on the right shoulder, that can be changed to a positive if you choose a different lead. However, you're never going to move the leads around yourself. You're going to let the machine change the polarity for you. Does that make sense? You're always going to put white on right, red on ribs, and black left shoulder. That stays constant. But the polarity that the machine assigns to that lead can change. For example, the way we described it, on the right chest is negative and on the ribs or left leg is positive. That's considered lead 2 when we're looking at an EKG like that. However, if we change the positive charge to the left arm, now it becomes lead 1. If we change the negative to the left arm and leave the positive the same, now that becomes lead 3. However, lead 2 is usually the lead that is used for continuous monitoring of EKGs. Okay. So I need you guys to pay attention through this, and then we're pretty much good to go for lunch. It says the heart depolarizes in a base to apex direction, meaning from the atria to the ventricles. The electrical current generated by this depolarization flows in the same direction. So negative to positive, it's going to depolarize in this direction. So current flowing toward a lead's positive electrode generates an upward deflection on the EKG tracing. So if you have your positive lead on your ribs and the heart's depolarizing toward that positive lead, when you look on your tracing, you'll see your QRS go up. However, if you have your positive lead somewhere else, let's say you put your positive lead up here on the left shoulder, when the heart depolarizes away from the positive lead, the QRS is going to go down. So sometimes the QRS goes up, sometimes the QRS goes down, and it depends on where the positive lead is located. Should I write that in the chat?
Yes.
So I wrote, sometimes the QRS goes up and sometimes the QRS goes down. This depends on the location of the positive lead. So if the heart depolarizes toward the positive, it'll go up. And then at the bottom, it says current flowing away from a positive electrode generates a negative or a downward deflection. So if you ever look at an EKG and think, you know, why is it going up here? And then you go in the next patient's room and it's going down. Why is it like that? And it's just because of where the positive lead is located on their chest. In the ICU, you come across lead MCL1 all the time. MCL1 has 4 different wires or 4 different leads. And the right, does it tell you on here? The positive electrode is placed at the 4th intercostal space in the right sternal border. So on the right side is where they put the positive lead. So of course, when the heart depolarizes, it depolarizes away from the positive lead. So in the ICU, you typically see a downward deflection with your QRSs. This lead is effective for monitoring QRS, complex dysrhythmias, P-wave changes, bundle branch defects, PVCs. That doesn't make any sense to you yet, so you don't have to give that a lot of thought. Here's a picture of looking at the leads placed for MCL1. Notice that there's 4. So the 4th lead goes on the right sternal border. So the heart is depolarizing away from the positive lead, and that's why the QRS goes down. Okay, and now we can stop for lunch. And after lunch, we have like maybe 20 minutes left of lecture and then putting the leads on. So we should be done before 2. Sound good?
Do we come back at 12:30 or 12:30?
When is it coming in?
Between 2 weeks.
Okay, so a little bit about the PQRST, what's normal, so that once we get into arrhythmias, we'll look to see if there's normal, and then if not, we'll be able to recognize it. So we're looking at the little P wave, it's the atria depolarizing. QRS is when the ventricles depolarize, and the T wave is when the ventricles repolarize. When the atria repolarize, we don't see it because it's hidden behind the QRS. So in the, pardon me, the atria have a smaller muscle mass compared to the ventricles. So when the atria depolarize, we get this little, I call it a blip. Here it says it's about 2.5 millimeters high. So that's the atria depolarizing. So when we're looking at an EKG tracing, we only see what happens with the cardiac conduction. We don't see what the muscles do. So we can't look at this and say, oh my gosh, the patient has an ejection fraction of 50% or 40%. All we see is the conduction pathway when we look at an EKG. The QRS, when we look at a QRS, it should be 2 to 3 of the little boxes that we see on the tracing paper. The QRS begins with a Q wave, and it shows here a little dip before you see the rise or the R wave. This Q wave rarely shows up. So when you guys have your tracing, we're going to look to see if there's a little Q wave before we see the big R. So the R wave is actually this big red line and then this big red line. That's considered the R wave. And then the baseline is called the isoelectric line. So when we see the R wave come back to the isoelectric line, after that is the S wave. And then we see nothing. That was it for QRS. So 2 to 3 of the little boxes. We'll look to see if there's a little Q, but even if we don't see it, we still call this QRS. So after the ventricles depolarize, there's a short period of time, and that's called the ST segment. Then we'll see the T wave when the ventricles repolarize. This J point, I've never seen, so I don't teach it because I don't see it when I'm looking at the EKG tracing. I wonder why my all right, now there's intervals and segments. We talked about the waves, and now there's intervals and segments. So the PR interval is the time required for the sinus node's impulse to travel to the ventricles. And to measure the PR interval, we begin with the very beginning of the P wave and measure to the first ventricular deflection, or the Q wave. So all of that is considered PR interval. And it's shown in yellow here. This is crazy. Let me try doing something else. Annotate, mouse. No, it won't change. So in yellow is where you see the PR interval. The ST segment is the end of the QRS to the T wave. It should normally be flat on the baseline. And you hear a lot about patients that have an MI or myocardial infarct. It's referred to as a STEMI. What that means is that on the EKG tracing, instead of the ST segment being on the isoelectric line or the baseline, it's elevated or depressed and below that. So that's how you can look at an EKG and tell if the patient's having an MI. One of the ways. And then the refractory period, it says it's the QT interval, beginning of the QRS to the end of the T wave. That should occur in less than 0.4 seconds. This is the refractory period of the ventricles. During this time, the ventricles cannot accept another depolarizing stimulus. But then as repolarization progresses, some of the muscle fibers are repolarized. All right, why am I telling you this? Here it explains the peak of the T wave, and that's kind of the point of all of this. At the peak of the T wave, it's a vulnerable period during which part of the heart can respond to an additional stimulus. A depolarizing stimulus during this time can create electrical chaos in the heart, rendering it functionless. All right, let me rephrase that. So if cardioversion needs to be given and the patient has the pads on and then a shock is delivered to try to convert the heart back to a normal rhythm, if that shock is delivered at the peak of the T wave, it could send the heart into ventricular fibrillation where it just quivers instead of contracts normally. So when cardioversion is done, it's always synced with the QRS only. You can't just deliver a shock to the heart at any time, because if it accidentally gets delivered at the peak of the T wave, it puts the patient into VFib where the heart just quivers. So that's why I'm telling you about the peak of the T wave.
The monitor does that for you, though, doesn't it?
Yeah, if you hit sync, yes.
Yeah, you charge and then but you don't do it in wait.
Yes. So what Chris is talking about is when a patient's being cardioverted, and the first thing that's selected on the monitor is to synchronize. And then that way, when the shock is delivered, the monitor knows only deliver the shock when there's a QRS. So it does it automatically. So in this gray area, if an electrical shock hits the heart at this point in the T wave, it can put the heart into ventricular fibrillation. Okay, so now for the EKG graph paper. A small box on the EKG graph paper is 0.04 seconds. So 0.04 seconds for the little tiny boxes. And then if you count 5 of those little boxes, it makes up for a large box. The large box will have a darker ink, so you can tell that it's a large box. That will consist of 5 little boxes and be 0.2 seconds. Okay, here's a picture of what we just talked about. So you're looking at some EKG graphing paper, and you can see some lines that are more bold and some are lighter in color. So the bold lines you can see consists of 1, 2, 3, 4, 5 of the little boxes. So this paper travels at a certain time, and right now it's showing you 3 seconds of graph paper. How many boxes occur in 3 seconds? You counted? 15? All right, so there's 15 boxes every 3 seconds. Large boxes. And then here at the bottom, it shows it's one little box is 0.04 seconds. All right, so when you're looking at an EKG, the first thing you want to do is determine the heart rate. And we do this in theory just so that you can understand the relationship between the graph paper and the tracings that you get on the graph paper. Because on the monitor, when you hit print and it prints you a strip of the patient's rhythm, it's going to show you the heart rate. So it's printed right on there. The heart rate is, and you get the heart rate. So we're doing this for theory to learn. So that's the first thing you do is you look at the heart rate on the strip. Then you determine regularity, and we'll go through how to do that. You measure between the QRS intervals. A QRS complex is also called an R wave. So when you're measuring, you measure between the two R waves. That's another way of looking at regularity. Then you look at the P waves. You look at the PR interval, and then you'll also assess the QRS complex. So that's how you're going to do it. Every time you look at a strip, you're going to follow this, and we're going to go through it. So the first way of assessing heart rate, it says to count the number of QRS complexes in a 6-second strip. And you're going to know it's 6 seconds because 6 seconds is 30 big boxes. So if you make sure you've got 30 big boxes, you're looking at 6 seconds. Then you just multiply by 10 and you're going to come up with the heart rate per minute. So that's one way. Second way is to count the number of boxes between the R to R intervals. So here's a QRS, here's a QRS. How many boxes are in between them? If you count the little boxes and divide the number into 1500, you get a very accurate rate. So I've got a handout and we're going to practice all of this. Or you can count the large boxes between the R to R interval, and that's going to tell another way to tell the heart rate. So if there's only one big box between this QRS and this QRS, you know right away that the heart rate is 300 per minute. If you count 2 big boxes and then there's a QRS, you know the heart rate is 150 per minute. And then 100, so we'll do that next. All right. So let me give you the handout. I'm missing 2. Can you share with Tiffany? I know. I mean, I'm not, so.
Sorry, Mary, I gotta do that. Unfortunately.
All right, so I gave you a piece of paper because what you're going to do first on that the EKG strip that shows up on the first page of the handout I gave you, I want you to determine whether that rhythm is regular or irregular. It's considered irregular if the distance between the R waves are different. So what you'll do is you'll hold up your piece of paper and you'll mark your piece of paper where this R wave is and where this R wave is. And then you'll move it and see if they all land in the same spot. So mark the first two R waves. You have to go down to this. Now move it along. See if they do they match up? They match up? Does that match up?
Would it be?
Regular.
You don't just eyeball it?
No. Okay, I can do it. So I just paper up between, whoops, put a mark on this paper here. A straight line.
It's regular.
And then put a straight line in this. All right, now take this piece of paper and move it over here and see if they're the same distance apart. Yes. And about here. Same distance apart. And about- So you come to the conclusion it's a regular rhythm. We're all the same distance. Did you get it?
Yeah, I got it. When I was-
No, it is regular.
Oh, okay.
We
have to figure out whether it's regular. So yeah, you have the.
We're going to Valhalla.
And then.
Wow.
Yes. It's more.
You guys said it?
Yeah.
This is the, no, this one.
This one's irregular, right? That's what it says on paper. It looks wonky.
You got it?
I eyeballed it, but I also did.
I didn't really take this one. I like it.
Same.
Oh, yeah, this is for the other one.
Oh,
yeah.
Wait,
I mean, I didn't throw anything out.
So the first and the last.
I have it all in
So this is irregular.
Really?
Did I check it?
That's one.
Okay, so
So this one. Okay, so start this one. This one.
all right, what about on the second page, when you look at the one on the top? You already noticed that it's irregular? Oh,
It says it.
and it says it.
Sorry.
But we did do it.
Look, I did.
Wait, the top of the page of the second one?
Yes, on page 2. Is the top one regular or irregular?
Oh, like even if it's off by the slightest, it's
It's okay to be
irregular.
off by 1.5 little boxes.
So then is that regular?
It looks.
It looks
Oh, wait,
regular to
1.5.
you?
If you eyeball it, it looks irregular.
Like you said, one.
Yeah, so you marked these two, right?
These two.
Oh, wait, it's off by like 2 or 3 small boxes, so.
So here it's off. Here it's all. So yeah, it's irregular.
Oh, do you mean like big boxes or small boxes?
Are the distance between the two R waves, are they the same throughout?
No, and then you said like, oh, it's okay to be like off by like 1.5 blocks. You mean like the big boxes or just these small boxes? Oh, small boxes, okay.
Yeah.
Okay, so yeah, then that's.
Do you have a compass? Protractor? You can use a protractor to do this too. Calipers.
What's your website calling?
Rico?
So instead of using a piece of paper, I have 8 calipers, if you want to use calipers.
Please. I would like to try.
What's calibration? What's calibration?
It's a tool.
You don't just look at two hard.
Wait, so what does that do? Oh, that's a caliper. Oh,
Oh.
how do we use that?
So
This.
you take off the cap and you spread it to the first 2 R-to-R intervals.
Oh,
And then you just lift it off the page, move it to the next
that's convenient.
interval to see if they're regular.
That's cool.
Which is the part one?
There's a lot easier.
Which is the S?
So you have these and do they have these in the school?
You can order them on Amazon.
Oh, you have these.
Are these used for lots of things? Or just
No.
EKGs?
Cool. Just EKG.
Oh, these are what they're made for?
Yeah.
Professor,
Interesting.
why are they different, the QR analysis are different types? You see how these are different types?
Yeah.
Did you make that?
Yeah, we measure the widths.
The
Measure
width,
the widths,
but
but you see how this one starts so high and then this one is so low? Is that- is it not measured with-
I was off by like 1.
and you wanted to move this a little bit out that and push. And just.
Usually I have to watch the video like 10 times. So if we're going for the bottom, that means that the just shows.
Okay, so now we're going to do heart rate. So page 2 is just practicing whether it's regular or irregular. And then the third page, it actually says page 89 at the top. I took these from the textbook. All right, so number 4, it says determine the heart rate using a 6-second interval and then multiply by 10. So I think that's 30 boxes, right? You counted? Okay. So we have 30 boxes. We know it's 6 seconds. Now count the number of R waves or QRS complexes, whatever you want to call them, and see how many there are.
15. Or did it come on?
Okay, so you counted 14 complexes.
14, yeah.
All right, now multiply by 10, and that's your heart rate. Got it?
14 times 10 is the heart rate.
Yeah.
But the 6 seconds don't. Yeah. Where's the 10?
Because if this is 6 seconds, if you multiply by 10, you get 60 seconds, which is a whole minute. And that'll tell you the heart rate per minute.
Ah, okay. It's a little confused. That makes sense.
All right, now let's do the next method where find a QRS or I'll call it an R wave just to make it quicker. Find an R wave that lands on a solid line. The first one.
This one.
Where it says page 89, number 4.
Oh, number 4, number 5.
Page 89, number 4. I'm still on the first one. So we said the heart rate was 140. Now we're going to use a different method to determine the heart rate. So find an R wave that lines on a solid line, and then count the number of big boxes. So there's 2 big boxes between them. Do you see that?
We're talking about these last two.
The first 2?
All right, so I'll put it on the other.
It's gotta be the last two.
The 2 to 3. No, this one right here, second, third.
Oh, I mean, there are more, but
Oh, I see.
so that would be 10 small boxes. Right? 2 boxes, 1. 5 by 5.
2 big boxes going up and down.
This is for.
Or this.
When you say count the small boxes, is it just like how many across? What are you gonna count?
Isn't the third heartbeat there? 5 large boxes.
It's the first one, it's the last.
So we looked at this. We know it's 6 seconds. We counted the number of R waves. There were 14. Multiplied by 10, the heart rate's 140 per minute. So that's one way to get the heart rate. The second way is to look at the big boxes between the R waves. So if you look at an R wave that's on a solid black line, if the next complex was here on the next box, we know that the heart rate would be 300 per minute. If it's on the next box, we know the heart rate is 150 per minute, which it is. So it's kind of a roundabout way of doing it, an estimation. And then to be really specific, you count the little teeny tiny boxes between the R wave. So we know each big box is 5 little ones. So there's 5, 10 little boxes. So now, do you have a calculator? 1,500 divided by 10 little boxes. 150. Heart rate's 150. So that's the most accurate way of doing 1,500 divided by the little boxes between the R waves. This only works for regular rhythms. If you have an irregular rhythm, then the only thing you can do is get 6 seconds and count. All right, so now that you know how to figure out regularity, you know how to figure out heart rate, let's do the next one. So number 5, is that a regular or irregular rhythm? You can use a piece of paper, mark the first 2 R waves and see if they're the same distance across the page.
They're only off by like 1 box. Yeah, they're off by 1 box. So it would be regular.
Yes. So if they're only off by 1 box, it's a regular rhythm. What is the heart rate? So you know it's 6 second strip. You can count the number of complexes.
6 times 10.
And there's 6. 6 times 10, the heart rate is 60 per minute. If you do the large boxes, so you look for a QRS that lands on a solid black line, and now you start counting the big boxes by going 300, 150, 100, 75, 60. Heart rate is 60 per minute. Okay, and now the next way is 1,500 divided by the little boxes. So you find the R wave on a solid line, count the little boxes. So it's 5, 10, 15, 20. There's 25 little boxes between the R waves. So 1,500 divided by 25 will give you an accurate heart rate. What does it come out to be? 60? 60? Oh. All right. Practice makes perfect. We'll keep going. All right, what about number 6 on that page, the last one? So 6-second strip, what's the rate? Yeah, now you guys can say beats and it's okay. I hear beats and it's like, no, oh, yes. All right, so quick glance, heart rate's 40 per minute. And then if you count the little boxes, nothing really lands on a solid line. You're gonna have to do a little bit of adding and subtracting there.
Over 6 boxes anyway, so it's gonna be less than 50.
Yeah, I get 38 boxes,
I got 38.
38 little boxes.
Yes. Divided by
1,500 divided by 38. I counted the number of little boxes between the R to R interval.
So that's half a box, so that's how.
So you can go up.
Okay.
39.8. So basically.
Oh, I see. Just a little. Oh, that's how you. Like a little.
Yeah.
Yeah, I was wondering. So.
That's what I mean.
All right, so the rest of this is just practice. So yeah, the last 3 pages, you guys can practice with that. So I just want to go through the steps one more time. All right, so we did the first part. We figured out the rate. We figured out whether it's regular or irregular. The next thing to do is to look for P waves, because not all EKGs are going to have a P wave. So that's what you do. You look for P waves. And you look to see if there's one before each QRS. So it should be PQRS. There's going to be arrhythmias where that doesn't happen. And you'll catch that, okay, wait, that's abnormal. I've got a P wave and there's no QRS after it. And then you measure the PR interval. Is it normal? Is it prolonged? So normal is 3 to 5 little boxes. If it's more than 5 little boxes, there's something wrong. If it's less than 3 boxes, there's something wrong. So 3 to 5 little boxes is a normal PR interval. And remember, you start where the P wave leaves the isoelectric line or the baseline. And you stop counting the little boxes to where the QRS begins. So my mouse right now is pointing to a PR interval that begins here and ends with the QRS. So I would say 4 boxes. So that's a normal PR interval.
Then the last thing you do is you look at your QRS, and the QRS should be less than 3 little boxes. 3 boxes or less than 3 little boxes. So where the QRS leaves the baseline to where it returns to baseline should be 3 boxes or less. Oh, I have one. Okay, so that ends the PowerPoint, and now I need you guys to hook up leads on yourselves. Give me a strip, and I want to see your P wave. I want to see your PR interval. I want to know if your QRS is normal. And if you had your banana today, you should have a normal T wave.
If this one's missing.
No, so you can't know pressures in the heart by looking at the cardiac conduction. No, because the AV node goes over and send an impulse, and you won't have yeah, we learned about that. Right. Yes. Okay. Tiffany?
It's like, it's for example,
So it's where where so I need to make okay, so I already have the cardiac monitor turned on. And then there, each one is marked. You're going to remember, where does the white one go?
White.
Where's the red one go? Red. What about the black one? Best thing to do when you're hooking a patient up is to put the electrodes on the wires first. They come in the leads. Put it on first. Remove the backing, and I'm not going to remove it because I don't want to waste it. And then you stick it on. So you can go in this way or this way and stick it where it's supposed to go. Or if you want to go behind the curtain, the privacy curtain, and stick them on, you can do that too. Doesn't matter the player that we put them on. Or should. No, you can do any order.
I mean, you can say it's where you. This can't be that.
Didn't Kim say that you can put one on the dressing over top to get the air?
I have a magnifying glass.
Oh, man, the first one might be different. Yeah. Wow, this is so helpful. I gotta go buy one.
You can use it for now. I need you to show me your script before you leave today. Yeah, so once you guys hook up, you're going to press print on the left side. And I need like, I don't know, 6 inches, and then hit print again to stop it. Then move the leads to your wrists and your left leg and hit print again and another 6 inches. There's only enough paper for today. That's why I'm telling you 6 inches and then hit stop.
If someone has an arrhythmia, we're gonna fight.
Yeah.
Oh, those self-diagnosed. What's your heart rate right now?
Oh, it's probably bad.
You're watching right now.
I'm probably so bad right now.
That's coming out of it.
Usually I'm like 75.
Mine's normally high. But yeah, I don't know.
Yeah, mine's like 75 to 80. Crazy.
Did you want to go? Are we doing them on our own?
We do it one by one.
Or do we go with like a partner? Oh,
Is this one?
Yeah,
Can we all like just stand?
yeah, yeah, go for it. I'm gonna go downstairs and make a few more copies. So Mary didn't get a copy, Marlene, and who else? And Brett.
I gave my.
so it's just Marlon and Brent because they
Oh.
gave it to the girls.
Chivalry. Aw, that's pretty nice.
Yeah, wait, that's what I'm doing right now.
So we'll leave right arm, right.
Do you know how to stop it from printing?
You said.
Press print again.
Right arm, left or right.
Is it yellow?
I did right arm, or under.
Yvonne. Yvonne? Which is this right? Yvonne, we should be seeing our heart rate up here before we record it, right?
Yeah.
Yeah. It's time to try.
Who's showing?
Yeah.
Is that a black side?
Oh my God.
Right.
Is the ring thing covered?
Okay, so like right here?
Oh, she blows.
Oh.
So there's a thing.
The less you move, the less the sharper the. Don't hit it twice, so just hit it once to print, and then you're done.
So, 3 of the limbs, or you kind of distribute them all, like the 2 legs and 2 arms. You see as you move, how you get it
This, right?
Right, these are super jelly, yeah. You might think this is here. Great, so I'm gonna take it off, just like waxing it away. Oh, of course.
Or do I stick it on my hand?
Anywhere?
Look at the professional growth.
Copies. Yeah,
Oh, it's there?
Right?
Yeah, typically, when it comes to lilies, if you want in the same distance. So if you're going to wrist, you want to get the other lily on the wrist. So you want like one lily, like lower leg, you want that like on the other side. Count 6
No,
seconds.
it prints it automatically 6 inches, but you have to push print again before it ends.
Well, you just count your neck, you count to 6. Just not 6 seconds. And that's not the print. 6 seconds.
I thought it automatically.
It'll just keep printing. Like when we're running code, we'll just let that thing pretty shocking. We want to see the rhythm. If we're cardioverting, we're gonna want to see the rhythm. We'll have that thing running right before we give adenosine or Venicard to see if it's chemically, because we want to see what's the underlying rhythm
Just like.
But yeah, she can do very good like this. We'll just.
Or just like, I didn't want to mess with it. I know, but wait, so I gotta mess up the. Yeah.
I'm not sure.
Right. Oh, wait. Left.
The way we was salt, pepper, lettuce, ketchup. Salt, lettuce, salt, pepper, salt, pepper.
Come on, let's go. Yeah.
That's what it's over the left side. Salt, pepper across the top, right? Salt, pepper, lettuce. Lettuce green, ketchup red.
So black goes on. White rice. Left black. So salt, pepper, lettuce, ketchup.
No, you look wrong. Red is always, red's on the left. Lettuce, salt, pepper, lettuce, ketchup.
Salt, pepper, lettuce. I just need to know.
So we're
So
just.
the white one goes
Salt, pepper, lettuce, ketchup.
Salt, pepper.
Lettuce, ketchup. You start. Salt.
Salt is white. So what is
Salt.
it?
Salt is white, pepper is red, lettuce is green, ketchup is
There's just white pepper, but like, you know, all.
Not that.
Color.
Salt,
Yeah,
pepper,
so
lettuce, ketchup.
that's how colors. That's how we learn how
How about the pineapple? Read on.
You're gonna lie?
Read it, go ahead, man.
Salt.
Typically, we try not to leave on a bone, put it on a belt. Those would be our rules, if you go up here. Just below the clavicle, up to the knee part, the joint. We're gonna be doing a 12 lead, that's gonna be a different machine. So we want to make sure we use it does, but here, something that's gonna. All right, so if it's a cardiac arrest patient and we're working them, they're gonna have pads.
Okay.
They're gonna have pads.
It's all
on.
that. Yeah, it's very okay.
They're gonna have pads on, they're gonna turn that thing on to paddles instead of leads. And then we're gonna have wall monitor. That's gonna have never mind, once we get a rhythm, we get a back, we get us. And we'll put something into its lovely to find out what the rhythm is. Because this thing isn't gonna tell us what kind of rhythm it is. It's just gonna tell, we'll be able to see if it's regular or not. We'll be able to- Do we need to get the pediatric leads out for Taylor?
You wanted us to get I'm sorry.
Yeah, come visit me at my
Old favorite station.
Yeah, because when you go in, I just went in there to check. No, she only went to do this stuff once. So I went in there and it's like, when you finally log in, there's like pop up that has like all this stuff.
The pop-up?
Yeah, I got it.
Mine's been popping up since like February.
I know, I got a good.
Yeah, we did the Ekg again, and I think like.
Yeah, it's like July.
So you did it.
Oh, they usually, it's.
No. Oh, here it shows. 1, 2, 3. Yeah. When the leads are placed further in the heart, and change some differences. Yes, no, that's all. Read 1, 2, and 3, which lead has the highest QRS deflection. What do you mean add 1, 2? This one, or this one? Two. Is the rhythm ventricle or
I know.
like between the R waves? Yes, with the same number of boxes. Yes. What is the rhythm? I gotta read and then what is maybe this is not. If not, I did take 15.
This one right
Pigeon, can you get me a calculator out there, Joe, please? Or second.
Please don't touch me.
I do, I see it.
Oh.
The little.
I put them on conversations to not go back.
Should I now must see? And it's the appropriate. Do you have a PA for each?
Squatty.
Now talking about the
One.
Yeah, 1/3 did. Now she wants it to be faster.
I'm successful, guys.
I'm so glad to be here. Thank you.
So you can tell it's an artifact and then
I was scared not to switch. That's the worst. But it was this. I was so scared that this was
you don't have to run the box.
Turbos go to 18 now. Yeah, right. 15? I do 7. No, no. 7.
Yeah. Hearing is like terrible.
I did everything. I'll show you quite a bit.
Usually it's like.
That's very.
What should I say? But not a 3. Not a 3. I think 5 and 5. All data. How much?
Yeah.
So, yeah, this for next month. So, you finish the same product. I see that. Everybody's marching. How much?
So that's you're right. No, it's just how fast.
Oh, yeah. Uh-oh. Yeah. Really, turn around, you're time out. You're big here, Harvey. Well, they need, yeah, they need you out.
Everything from there is like something.
Rachel, we're sorry.
Someone.
There's no preparation. Yeah, I know. It's okay, I'm already jacked up. I know, I was on it. It's perfect. We can take this. Let's just take it here.
Who's next?
We got
He said, really? Yeah. I was holding your spot.
Please don't judge me. There you go.
To Valhalla.
Yeah. Yeah, that was it. Thank you. Mary, are you next?
Wait, can you tell me now?
I'm kidding, I'm kidding. We're just on- we're just kidding around. I know, that's why I know. I can do that right now. Sorry,
I'm alive.
good job.
You know, you know.
Red is red.
We're actually done already. So if someone can come now, yeah. For some of us are done somewhere, but we're just. going
No, that's tomorrow.
No.
Tomorrow,
Friday.
Are we doing this together or?
Tomorrow.
I wanted to make sure.
Especially now that we're like.
All right, Like we're supposed to know that, we're supposed to know that. I look at this shit. Where is the position?
Okay, sweet, 'cause I was gonna say, I was like, I'm trying to try and get ready for 30 minutes when I get there, so. it works out that I got up early. Sweet, I'll text you when I leave here. Alright.
He said yes.
Early because I told her I couldn't stay with
I don't know that one. I can't. If I can get the lecture online. On myself.
I happened to be on with my email open, which I never have open. Checked it out, I'm like, oh my God, there's a class.
I am driving, so.
Like, I analyzed that one and then.
We're almost out, right?
Oh wait, yeah, how many of you end up having online? There's a video we have to post? No, I hate that. I'm gonna do it like right. I think that one is. What's the 5 questions? Like, what is your career?
stuff like that. This is a. God, I hate you. I could just type it up. It's fun. Wait, so are you still in the in-person? I got you. Get out. I know, and then I was like, the class we were in though.
Yeah.
Like, your lecture on Don't forget, guys, bring everything first and hold on. We're at the swim center, she said bring everything.
Yeah.
And lunch. Everything. Nine, right?
Stethoscope, what you got, whatever you got.
And lunch.
Listen, this class, this is not new, so if you have questions about how to read strip or figure out a rate or something like that. Yeah, no, I didn't put it.
Little slides.
It's bad. Totally not. I was so lucky.
And how long is this video?
You have it on. Yeah. You was on. I was online. Yeah. No. Yeah, she's interesting.
Okay, so, like 3 to 5 minutes.
Okay, mine was talking about you know when the Indian spaces. What is it? We just talked really fast. Yeah, I don't know what we're talking about. Number one. Select the yeah.
No,
Let's
it's
do
from
Okay, here we go. Okay, Prince.
Oh, really? Okay.
You'll see it on Friday.
Tell me what you guys, these are rumors.
God, I did.
Whatever the line is good.
So, all right, it's just a lot. So,
No, you know what else?
What I'm wondering is when you put on the fourth week, did you put it on the right side?
It's not.
Maybe try putting it on. If you have
I think all of this is actually.
and then right underneath it. There's nothing wrong.
Are you?
We have kids. Well, I see why it's so say this.
I guess there are students. I guess some of them are going to the clinic.
Yes.
Okay. Or I'm looking at it. There's a rumor, I guess, that they'll be leaving class. Okay, so. I'm in Berkeley. So I gotta go get I'm gonna go get my stuff, my guts to work. So
Oh, here you are. I'm about to call you. Where do you gonna be around?
Around 2.
Yeah, they're finishing up now. Like Taylor's already done. So she can get started.
There's only 3 of them.
4. All right, I gotta go get this stuff. I gotta go get it unlocked. So I guess if I eat this.
You sure?
Yeah, just want a card. See, that's not good, right? See?
So
If you want pretty much.
I'll be back. It's gonna take me about 10 minutes to go get all the stuff ready to get unlocked. Just before you go, no matter what happens, earthquake, tornado, whatever, just stay right here. And I'll be right back.
So where did you put it? I'm just wondering. Rachel's kind of like this. I wonder why. I'm just trying to figure out why it's not enough reflection. It should look like this. In yours.
Does that look right to me? I don't think I should print it.
Oh.
Oh, yeah. I just love the two.
This was one expressing.
Yes.
Yeah,
Stand up.
Isn't that supposed to?
Yeah, so in me too, just when you get your reflection, because the heart circulation force a positive. So I'm wondering why.
This was. On the side of the leg or the top part of the leg? On the left or the side?
Sure.
Yeah, yes. Is the rhythm regular?
So bad.
Keyboard. Certain medications also affect this, yeah, so I used to call it alcohol.
I got great papers.
What is the weight? So you can count, because it's probably only 15 boxes instead of 30.
I start from this right.
Doesn't matter. It's not enough to do 30. So count off 15 boxes left. Yeah. And then how many hours do you have? In this 15 boxes? You multiply by 2 instead of 10. Both at the same time.
Yeah.
Okay. I now count the small boxes and then divide them into
That's right here. So, yeah.
Okay, quicker way to do it is, you know, the big box is 5, so it'll be 5, 10, almost 14, so 200.
Yeah, that's right. Are there?
Where you go?
Oh, it's 6 minutes back.
What's wrong? You just went to the company. This.
So, right.
So yeah, that little wave is the key wave. Mhm. It's there, it's easier to see them. They rise before us.
Always that one bump right before.
And then how long is the P wave? So you start counting at the beginning of the P wave. As soon as the P wave leaves baseline to where the QRS begins.
Where would you base?
So I always look before the P wave, and wherever this is the baseline. That's baseline. And then it goes up and start counting. Can you mark them and put it a line where you start and a line where you stop?
It's less than 3 over 5.
Oh, where's that?
Oh.
So draw a line like this. Who the 5 is small? QRS. How many boxes is it?
Are you counting the big boxes? Or are we counting?
Very good. So less, anything less than three. Three or less.
You know, now it's not. Hold on.
Francis next.
Yes, ma'am.
Okay. And usually lead two has the biggest QRS deflection. And in yours, lead one. No, I just, sometimes I don't know how that's going to, it's like, why is this so small? Yeah. Ah. Yeah, I don't know what I need to do. So we'll see that. Now, it has to do with placement, like wherever you put your, what about your positive? So maybe it was lateral, more so than interior. I don't know. No. Is the rhythm regular? Want to use calipers? What is the what are the count number of ROAs by the 10 bar?
Yes.
This one, they're building one. Yeah, but I'm sorry. No, I don't believe so. Yes, and by.
Do you have feelings?
Right. We just moved down into the release 3 years ago. I remember this is how yes, sorry. We can see right here.
You ready for this? Are you ready for this? You ready for tomorrow? I gotta find my stuff.
Yeah, I gotta go find it out.
Oh, yeah. You did yours again?
I have to. Let me see yours.
Mine was so
Yours is like mine.
Yeah. But then, we're back.
Yeah, you start counting when the. I'm asking you about QRS, your ratings on this, so why don't you say yes, you are correct. Yes, that's wrong. Sometimes I don't, my muscles are all bad.
I would practice, so you can practice.
Good job.
Thank you, Professor.
Yeah, 9 o'clock, guys, don't forget.
Tomorrow, no, guys, bring everything ready, guys.
Thinking I have my
Stephanie, tomorrow. Just a pure nervousness. For tomorrow?
No, I woke up in the morning. I was looking one.
I was nervous when they was dropping lesson after lesson after lesson. You want me to help you? Come on, Rachel.
All right.
Come on, 3 rounds. Wait till I get a. Wait, salt, pepper, lettuce, swap. Get it right above the rib.
I don't know.
That's too high.
All right. The next
I'll
one
go
right
right
here. I'm gonna try you small. They'll be the ones for facing seriously upside down clinic for a couple days clinic until we get time. We used to use
Where's your salt and pepper?
top strap on, just around
Salt,
of the ears.
pepper,
Bottom one. heavy load strip. So it goes somewhere here on the top of your head, it's not gonna slide, so it's basically across.
So how many boxes?
Your heart is.
Just around on top of your ear.
So kind of the large boxes.
When you put a hold your back.
Maybe it's
You find a place where it sticks to your head, where it's not gonna
super
slide.
No,
And then you kind of do your.
so multiply by 10, you
50%.
Oh, that's right, okay.
50%. So you're.
So
On the other half of the
Yeah.
and then what about 600 divided by
They're real short wear because they're tight. Next, we put you in this fabulous hood.
I'm here next.
You can taste that.
It's the whole back, upside
You may
down.
be able to smell it.
Like, not just more like for real.
All right, move your left knee more anterior, like it should be on the front, not over on the side.
over here. My ribs are here.
Yeah, put where your finger was.
Right here?
Yeah.
That's where I had before. So all you can do is, if the mask gonna come in two sides, all you can do is try to adjust it more. Pull out when you was your straps slid down.
It's the one that What did you think? The red is on the left. Yeah.
Yeah, so people also put paper tape around there. Like, a lot of the hospitals actually have your paper mask on top of them because they don't
Try to
know
play with it.
where you been at.
Maybe
We'll play with it. Doesn't. Do you have to wear your paper on top of it?
Or try to do the, try to present one on the arms. It's the same thing here. I'd be.
Yeah, it's
Okay, wait, now I'm going to go with
You're fine.
Achilles.
All right, you can go to the press.
It's just an exercise.
No. There.
So one plate with
Okay, turn your head to the right, take a deep breath. Your head to the left.
and how long is that here?
Taste it.
How did you
Feel
feel?
it. Yeah.
So hard for me to see.
It's true.
Like, nothing up. Size stuff.
And then how many boxes does the?
It's the exact same mass.
Less than three.
Yeah.
You're getting that kind of.
It wasn't that strong, but I felt like.
It's not.
Try.
But I don't see.
Yeah, it's like a sweetheart.
Everybody should have a.
Not a good one.
But it's normally, yeah, it's hidden, right?
It's basically like a sweet tart.
I don't know why.
Yeah.
Why we don't see it.
Me either.
So wherever that is.
Love it.
And then where this comes from.
So.
So I guess more verbal remarks, we'll try to exhale. Breathe in.
No, they're not.
You exhale, do you feel any leaking?
Do you wanna?
Yeah, maybe for my exam, I'll have to bring my class, just so I don't get things wrong. I can't see them.
Oh, Steve.
Maybe your glasses are too.
Well,
Your glasses
This
were.
is, this can't be that side.
Yeah.
This particular brand.
Oh, damn.
No, like I'm.
First get this store.
Alright, so
Well,
it's
it's strong. You know that how strong Alright. Yeah. And look up to the sky.
Oh, for the section. So the further away, the smaller.
Okay. Yeah, no. I let you taste the real one. All right. So when you get there. No. You know what? After we adjust it, it's okay. That's 1860.
Thank you.
Yeah, she gets my pen.
What's coming? Hold on. Oh, it's my pen in my pocket.
So, right here, you're gonna have your name out, you're gonna put for our college name, for our college students. You don't throw out anything on this page except the two. Sign.
Is there one?
Part two is medical questionnaire sheet. This is the document. About this name for our college student. It's the questions, you're still gonna repeat themselves. Not them, just- I just hear it. Don't sign. No, that's for me, I gotta check my test. Okay, so there you go. I got one more.
She's right there.
Okay.
Bye, guys.
You are. So we come here. Prints it out another one.
Name, your college's student. Get everybody go.
And.
Did you get the custody of the or not yet? Shake, I know she said.
Yeah, but she.
Did you get custody of it?
No.
Okay, so
Always leave
yesterday- yeah, she-
You have to do the paperwork again.
she was sure when we-
I know.
Yeah, she just sent it to me this morning. I could do it today or tomorrow.
In the middle of class, don't leave.
After the form. That looks like one box. That's everything.
What's your name?
Good job.
Our college student. Let's do that in this first. Name, date. What? And then the next one, date, name, our college student. Answer all these questions, some of our. And here.
Yes. Thank you.
You're welcome.
Right?
So you did chest needs and then you did leg needs. Do you see any difference between them? So it looks like the deflection is larger when they're closer. Compared to the other way. Did you see any other factors? There's not many squiggly lines. This is like the most strip I've ever seen. There's no movement, everything is very clear, the key ways are very clear. Is the rhythm working? Or-
Now. It's a pleasure being help here. We might want to make that shorter.
And then
not
also
longer.
1500 messages. Yeah, that's a good one. How many is that?
You want to shine side. It's better. It could be slide, right? Plus, here.
Yeah.
That's how you all right. All right, so the spray that I'm going to use is actually a second one spray. Spray. So when you said yeah, sort of. So right now, I would say you have one, but you're
And
not sure.
the PR interval, how many bounces?
All right, I'm gonna give you a taste of what you're gonna be tasting for right here. This is gonna taste a little bit sweet, maybe very faint though. All right, kind of open your mouth.
And you're counting as the PA begins.
This water is really close.
Now.
Not bad. What I hear is once you put the mask on, you use a stronger concentration. You should be able to
Yes,
feel
and
it
this
back.
is-
I'm not saying you won't be able to smell it, because it depends on how well you smell. You guys are more too, so you're like, that feels fixed different. This really kind of sucks in the face too. So you're gonna put the top strap on like you normally would right over your ears, but this bottom strap, yeah, you know what, look in front of your face this way, you're gonna use one hand, and bring it up here and lock it somewhere where it's not sliding. That way you got a lot of cross coverage on your head. There you go. I'm gonna try you as large, because you have a larger face. I think that's gonna work for you.
That's everything.
That's good. That's how you do it. You can be sad all we want.
And then.
That usually does all the time.
Okay.
All right.
So.
See what I mean? Your chin doesn't get locked in all the way up to this particular mask because you got that hair. Awesome, nothing about that. That's what you use, okay? Or the Pritzker. Slide over here a little bit. So I can. Don't be afraid. I haven't taken one student yet. You have to study this.
There was the QRS.
All right, we're taking a couple deep breaths.
QRS here.
Turn your head to the right, take a couple deep breaths.
The QRS here.
Turn your head to the left. Take a couple deep breaths.
Does that make sense?
And
You're welcome. You can go home.
you're gonna go look at this.
Are you ready? Okay. So did you do a tracing with
Back to group. All
electric?
right, last part of the test, delicately stand up, remember you're on wheels. I'm gonna bend over the waist a little bit. Let's see. That's what I like to hear, that's excellent. All right, I mean, now that's gonna be a mask for clinic, that might be a mask for the first day, might be your first week and stuff. So hang on to it tightly, don't let it get all messed up, banged up the farm. I know you're used to wearing it, but when they have to resize, you just like walk like that. You got it. Well, your face is gonna be sliding, but yeah, because it's gonna, you're gonna see it's gonna grab your chin. There you go.
So, yeah.
Sorry about that.
It's okay, Miss. Have a wonderful day. Thank you.
We want you to be happy.
I wanna be safe.
Yeah.
No code for me.
So what is it?
9 o'clock, we gotta be there at 9. At the Sim Center. 3.
Don't be late.
I'll remember this one.
I'll be back.
6 seconds. 7, 10.
The same rules that we gave you for you. I'm gonna spray this so you know what you're tasting for a little bit. Here's my sweet tart.
And then another way to do it is 1,500 divided by the
Joyful? Yeah, what size were you wearing oral? Regular? Small, so small. I can't get my small. Look at your head, right? I'll try you large, just because it squished in there. All right, so you kind of saw my directions. It's up to you. So this is gonna go over your ears, and then this one, we saw you hang on to the mask and look to the corner and find a spot where it's gonna anchor, not slip back. The idea is that it's not slipping back, so it's over your ears, just like the other strap. Let's try you with the large, see if we get- and then we can adjust your nose strap. Your nose being there. Figure you got a lot here. Right, so if there's too much room, we'll. So there's and these faces. Because now you got a metal band up there, you wanna make sure that counts. The nose.
Mine still came out weird. I'm freaking out still, a little bit, not as much anymore.
So you start counting the
Actually, it does.
So
It's very reasonable. Right, I'm taking some deep breaths.
And the QRS should be less.
Taking some deep breaths.
I don't know what to say.
And.
So let me tell you what I meant.
Okay.
I know when the heart depolarizes forwards, the positive electrodes.
Sitting in the back of the grip. All right, Tracy thinks that you delicately, since you're on
So
the
as long
stand
as you
up.
have the positive electrode in your heart, it depolarizes forwards the electrodes. And over the side, you'll move it. I have
Here you go.
here, and I have it already.
You could be out more pat, you know, follow your role, you might change whip up some shade on that, I don't know. So for right now, I put this right there.
All right, Jimmy?
Yeah.
You good?
Yeah. I just gotta go to Michael.
Yeah.
That's 41 minutes there.
41?
Yeah.
You gotta go. Man, it's 30 minutes. It's 30 minutes in the car. All right, take the turnpike south. Take the turnpike south, get off on 5 East. You're.
I'm not doing my road.
Huh?
I'm not good with my like road.
Turnpike right here.
Oh, it's get on right here?
Yeah. As soon as you come out here, you see the highway right here?
Yeah.
Make the left. Yeah, you can follow me.
But I don't know what I'm gonna do. Daniel, are you gonna go straight to Michael?
No, I wanna go pick up my daughter. And
And then you're gonna go?
Huh?
And then.
Yeah.
What do you need to do?
Yeah, such a six, but I also don't know that campus and I have no idea where. Campus is like.
The building is plastic. It's in the back of the campus. Just follow the road around.
Well,
No.
Yeah, furniture went to go check it out yesterday.
Bro, start, it's in the back building, second floor.
Back building second floor.
Yeah, building 61 or 60.
Yeah.
Something like this, new building.
Sure.
So I mean, just follow the road around. Or you can park in the front and take that long ass walk through the campus. There's parking right before your door. My campus. You live up here? Turnpike South. Turnpike South.
I had to modify this stuff. Usually you would lock them in and then we would.
We'll drop you right to the campus.
You can't have people that are unmasked. That case disaster. So we got permission to give the testing solution orally. In the house, we give a sense of the taste. So here's your week dose of sweet tarts for you. You look so impressed. Why are you hiding? These are sugar-free sweet tarts. This. Chocolate's always chocolate's for you. How do you feel about carrot cake? I know how I feel about carrot cake. Carrot cake's pretty good.
I haven't made them carrot cakes. I don't know.
I don't know anything about
You made
that.
good carrot cake?
Oh, yeah.
That's literally like my cake on the.
Look at that. See, I knew that right away.
On my birthday's in a few weeks.
Alright, so this strap goes around on top of the ears. And then yeah, this one you're gonna, you take one hand, hold the mask, and then bring it out in front. You want to stick it somewhere in your head, like somebody slide and try to find the level, and then you do the nose piece after. Joy.
Have a good evening, guys.
Bye. Well, take the top strap first. You got your bottom strap.
The bottom strap
First.
Oh, yeah, you're
Now you anchor it by pulling it up and finding the spot where it's gonna sit on your head without sliding down. Tight, right, and you got plenty of room to adjust the mouthpiece there. Yeah. No, no duckbills over there. You see, I don't like the duckbills much. I wear that. We always have to wear.
I always love the duckles of it, like straps or like rubber.
So they pull your hair.
Not only that, but they just get really tight sometimes.
Gotcha. All right, here's your Vulcan helmet. Made it. All right, what you can wear. Set it back up here. There's a hole in front of the center. All right, we have you turn your head to the right. Take in some deep breaths. And turn your head to the left. Take in some deep breaths. Feet. Take in some deep breaths. And now you're gonna look up at the sky. Take a couple of deep breaths for me. Taste any sweet tarts in the back of your throat. Hey, all right, last part of it, delicately stand up because you're in the chair wheels. I'm gonna have you bend over. And you're gonna say a few things to me. Okay, what else you got?
I don't know.
Yeah, unfortunately.
What do you mean, unfortunately?
I do. I love them. I don't know how it is. I got stuck with cats because we have a dog. I think there's so many cats do that. 6.
And y'all think I'm crazy, okay? I have 4.
2 of mine are outdoor, indoor cats, so they go out at night and come in.
That's
My 4 main ones are in that.
mine stayed inside.
All right, Rich, you were a size regular, so when they go to replace that or renew it for you, I don't know what their changing schedule was. That last year, the first day clinic. So, well, I would take that one at least for the first day of clinic, and then you get your size for that. Yeah, I just adopted a mother cat, and we left her kitten on the doorstep. It was about 10 days old. So we were gonna take it to Peggy Adams, and then Peggy Adams said, don't bring us any kittens that need to be weaned, because we don't have enough foster parents. So I said, all right, I'll bottle feed it.
And you do that every 2 hours schedule for that? Both of my cats, my one that was hidden, they were like a month old, so luckily they have their teeth, and as soon as they have their teeth, you can feed them regular food.
Yeah. Fucker, now he's got his teeth, now he follows me everywhere.
What color is he?
Cat, gray cat.
Oh.
He's got a little crooked tail on the end, so his tail looks like a little question.
Oh.
You should name him Riddler. I'm naming him Thor. Oh. It's like, I only have one boy cat, and he's the bane of my existence. He's a demon. And my boyfriend's like, no, I was gonna give him to my friend. My boyfriend's like, no, he's my only boy. Oh. There's no other boys in the house but me. I want him. So we kept him, and we have a cat. Oh wait, I'll show you. Somebody must have given it. I have my phone downstairs. Somebody must have given it. This perfectly good cat. So he ended up at my house. I hate when people do that. It's like, how do you leave your cat? And this cat is so well behaved. He walked into my house and yelled, "It's my baby." Her name's Mo. She's a brat. And Crushing, she's orange. So I can see her. Yeah. And then I have a black one and two black ones and two straight cuts. And look at this green. It's so cute. That's Tabby and this Jasper. That's all I knows. These birds is no one cats. Only because they were found around the same area and they were the same age. They both had that line of everything. So they're like, "Hi, Mom." This is like, "Return." That's not me. I got a Coco. She's 8. Yeah, it's a Coco bear. I know black cat come and see dad. Mom, if there's ever a lizard in here, I would gladly be out.
I didn't hear you.
Look at the size of the one I picked up at work. Yeah, I put him outside.
You did?
My boss is like, he's been back there for over a week, and I'm like,
Oh, my word.
oh, well, you're welcome, because no one else is gonna pick him up.
You don't mind holding him in your hand? They're loaded with salmonella.
I washed my hands afterwards, ma'am. I know, I wouldn't kiss it as much as I would want to. Turtles have salmonella too, and I've saved those tons of times.
Oh, really?
Yeah. I'm one of those weirdos that will pick up a turtle on the side of the road and return it to a water habitat. So
Oh, that is so kind
I
of
like
you.
animals. I'm not too sure how I feel about picking up one of those giant green iguanas though. I'm still a little iffy about them because they're kind of wiggly. They got teeth. No, my pharmacist, I work at CVS, and my pharmacist showed me a picture from one of the other CVS pharmacies. Somehow one of those iguanas we have out here, you know, like the regular size, the big ones now. Not the jumbo ones, the Godzilla ones, but like the pretty big ones, like 3.5-foot ones. Wound up in one of the CVS pharmacies, in the pharmacy, and he was chilling in all the drugs.
Oh, my word.
They had to call someone to come in and catch him. That's hilarious. This is it. Do you want this, or do you, I guess I'll stir it out?
Yeah. I'll see you next Tuesday. Thank you so much for doing that.
Oh, you're welcome. Yeah, Kim sent me an email early this morning. I was like, oh, okay. It was either today or I had to try to catch him down at Central tomorrow, and that's harder on me.
Yeah.
How
did Brent work out with this year?
He was okay. He knows he's gonna go home and shave it tonight. I told him because it feels like it's slipping. I know that's because you got all that hair, so. I'm gonna take it all off tonight. I said, okay. Fit, he made it. Girl with a real tiny face, Taylor, we had to really adjust that mask for her. Oh, really? She got a really small face. And out of all of them, you can tell by the personality. I only need to meet somebody for 30 seconds before she's a little bit more paranoid when she's a little bit afraid. That's okay. We're gonna start somewhere, right?
Yeah. What sizes do you have to offer them?
This 3M only comes in small and regular. So even the small was even a little, well, it wasn't that big on her, she just had to really position herself.
Yeah, that helps us out so much.
Yeah, well, I can grab them when I'm here and I can do them when I grab them.
Yeah, it's good to know ahead of time so you can
Well, the next problem is, I don't know what they're gonna do, but they know, they don't have any smalls like that, so all we have is regular, and thank God I had some smalls in my car for the X-ray students. But pretty soon I won't, they're gonna order a few more, so we have them for everybody. Especially if we still have to do the primary first test on a lot of the students, then once they get to the hospital, they'll give them 4 masks as needed. Yeah,
So who orders them? Can you tell me what?
usually Lori, and I guess she's waiting to go ahead for Laura or something.
Oh, I see.
But I haven't followed up with her really, but I need to ask her. But they're better now, those 4 off the plate.
Yay.
All right, I'll see you next time.
See you next time, Mary Ann.
Thank you.
This goes down.